All right. Hello, 241 students. This week, we are moving into chapter 9, talking about articulations, aka our joints. Okay. So in this chapter, we're going to be looking at all of the different ways and methods that the bones in the human body meet with each other. Some of those joints, those articulations, are going to be more structurally stable, and some of those are going to be more flexible, allowing for more mobility. And there tends to be a trade-off between those two properties. The more stable that a joint is, the less flexible and mobile it will be. The more flexible or mobile that a joint is, the less stable and more prone to injury it will be. So we're going to be looking at our classification of our different types of joints, and then from there, basically focusing on one particular type, our synovial joints, through the rest of this chapter, because those are the ones that are doing a majority of the movement, or that really have any significant movement to them. So synovial joints are how our skeleton is moving our body throughout our universe with help from muscles, of course. We'll introduce all the different terminology for the different types of movements that we use in anatomy and physiology, and then look at some specific joints such as the intervertebral discs, the elbow and knee, and then shoulder and hip. So a reminder about our different types of cartilage, as we're going to see two of these types showing up a lot here, and then some new terminology that some of you may be familiar with before we jump into the rest of that stuff. So the reminder about cartilage. We have three different types of cartilage in the human body. The ones that we're going to be seeing a lot today as we talk about bones and where they meet with each other are going to be hyaline cartilage and fibrocartilage. So elastic cartilage, which as the name sounds, it is quite elastic and flexible and will snap back to its original position, is really only found as support in softer tissues. A lot of those tissues actually start with E, so we have ear and epiglottis here. There's other E structures that all have some support from elastic tissue. But in our joints, we're mainly going to see hyaline and fibrocartilage. So hyaline cartilage is the most fluid of our three examples here. It is a viscous fluid. And in our joints, it is going to serve as articular cartilage, which is going to produce some lubrication for where the bones would meet in a joint so that they can kind of slide off of each other without really rubbing on that bone. Hyaline cartilage is also what serves as the model for endochondral ossification, as we introduced in the last chapter, so how our long bones are formed. But here in our joints, this is going to be forming our articular cartilage with some slight modifications to comparing it to hyaline cartilage in other areas, but we'll talk about that later. And then fibrocartilage is going to be providing a lot of the exterior support in some of these joints. So fibrocartilage, as the name sounds, is extremely fibrous, and so is there for strength, resistance, and resilience. And so we'll see that make up some of our accessory structures like the meniscus in a lot of our synovial joints. We'll see it make up a majority of the supporting structure of things like the intervertebral discs between the vertebra of your vertebral column. And then fibrocartilage also composes basically the entire joint of our symphyses joints, such as the pubic symphysis. And so some other terminology that is as new to this course so far, but you've likely heard these terms many times, or we may have talked about them in other scenarios, but that is the difference between a tendon and a ligament. These are both dense connective tissues with some slight differences in common structures that you would find within them, but basically they're the same thing. It's dense connective tissue, lots and lots of collagen fibers. But the major difference is that a tendon connects muscle to bone. A ligament connects bone to bone. So tendon is muscle to bone. Ligament is bone to bone. So a majority of the support that is going to be holding bones together in these joints is coming from ligaments. And then we get some additional support based on these surrounding structures, all the muscles around it, and their tendons, getting some of that extra dense connective tissue for these things to push against. So tendons connect muscle to the bone, ligaments connect bone to bone. All right, so with that out of the way, let's talk some specifics about our joints. So we categorize joints by function and structure. So we have three different categories of functional separation. We have no movement, some movement, and then lots of movement. So our no movement functional category is called synarthrosis. So any of these joints are synarthroses joints. Syn, referring to no or lacking. So this is no movement. And then structurally, we have all three of our different types of structural categories. So structurally, an articulation can either be fibrous, cartilaginous, or bony. So the joints in the body that aren't supposed to move, that aren't set up to move, and typically will not move, are these sutures of the skull, the gomphoses joints that hold your teeth to your jaw, the synchondroses joints of the costal cartilage that spans from the rib to the sternum, and then the synostoses joint between where these bones fuse at the front of the face, right, the front of the skull. So none of these articulations, these meeting points between bones, should allow for any movement. And they're in areas in the body where movement shouldn't really be necessary. And in fact, where stability is much more important. Okay? So again, keep in mind that trade-off. Where things are not mobile, they're typically going to be much more stable. Okay? And as you increase mobility, you are doing that at the detriment to the stability, the less stable it will become. So these joints don't move, but they are extremely stable, less injury prone compared to some of our others. And so our sutures and gomphoses, those are fibrous joints. They are mainly, you would mainly find fibrocartilage between them, or just fibrous, dense connective tissue, I suppose, instead. These cartilaginous synarthroses joints are synchondroses. That is lots of cartilage, so mainly fibrocartilage and some hyaline cartilage in there. And then the synostosis is just bone. All the cartilage that was originally there should have been broken down and just replaced with fused bone. So as we move up functionally, where we have joints with a little bit of movement, these are amphiarthroses. Think about like amphibians, which are kind of the middle ground between a fish and a land animal, or sorry, an aqueous and a land animal, right? Amphibians can kind of do both or a little bit in between, or an amphipathic molecule has both hydrophobic and hydrophilic regions to it. It's the middle point. These amphiarthroses joints are the middle region between synarthroses and diarthroses. So these provide a little bit of movement. And we just have two different structural categories or structural examples here. We have fibrous joints, these syndesmoses, such as the ligamentous connection between your tibia and fibula, right? Holding those bones together, but they don't really need to move very much around each other. We have a little bit of gliding motion. And then our cartilaginous amphiarthrosis joint at symphyses, like your pubic symphysis. This really doesn't want to move very much, but needs to be a little bit flexible in order to deal with the stress or load or movement being so low in our body and having so much weight compressed onto it. So that cartilaginous symphysis allows for a little bit of flexion and stretch, but overall there shouldn't be much movement there. So both of these joint types just have a little bit of movement. But then our last category are diarthroses joints, which are structurally only going to be synovial. This is going to be where we are spending a majority of our time this week, and is the major focus when thinking about joints, because these are the most mobile. This is how we are moving around our universe, by having muscles pull on bones that form synovial joints. So these provide the most mobility. These are the most mobile. And so we're going to further distinguish or categorize different types of synovial joints based on how mobile they are. So we'll have some that are monaxial, meaning they move on one plane or one axis, biaxial, moving on two planes, and then triaxial, moving on three. So we'll go from kind of just flexion and extension in one direction to allowing flexion, extension, and circumduction, right, multiple directions. And then with our triaxial, that's introducing rotation as a possible movement. And so these are all different types of movements, different planes that synovial joints will be capable of. So like I said, this is where we'll be spending most of our time in this chapter. They are diarthroses, or allowing for free movement. So let's look at our typical synovial joint. So synovial joints are going to all have a joint capsule, which is basically all this space that you see inside our synovial membranes on these peripheral portions, and then the articular cartilage making up the surface of where bones will meet. So this almost continuous membrane that completely surrounds this space, this capsule full of fluid, synovial fluid, that is your joint capsule, your articular capsule. Okay. So within that, we have articular cartilage, that hyaline cartilage, that is going to make up the lining of where the two bones in that joint, or three bones in some cases, where they meet. But this is hyaline cartilage without a perichondrium, so without that connective tissue on the outer layer, and has a much more watery matrix, allowing it to provide much more of a lubricant rather than a structural thing, more than a structure, right? So acts as lubricant between where those bones meet, so we aren't just rubbing our hydroxyapatite crystals onto other hydroxyapatite crystals. We get some fluid movement from that articular cartilage. And then the rest of that joint capsule is lined by this synovial membrane, which is going to produce synovial fluid. So synovial joints are surrounded by synovial membranes, and those synovial membranes produce synovial fluid, which is going to fill the rest of this capsule. Synovial membranes are areolar tissue with a thin lining of incomplete epithelia. And that areolar tissue, the cells within that areolar tissue, are what are creating the synovial fluid that gets pumped into this space. And so that not only creates room in this joint for movement, but that's also going to be where nutrients and waste are diffusing to all the bones that make up the area around this joint, and helps with some of that compression, that resistance to force in that area as well. Right. So all that together makes up our joint cavity. And so we're also going to be looking at lots of different ligaments in this week's chapter, as we look at specific joints like the knee, elbow, hip, and shoulder. And so we'll refer to them as intracapsular or extracapsular ligaments. And so those are ligaments that are in the capsule, intra, or ligaments that are outside of the capsule, extra. So we get a little bit further support by this continuous lining of connective tissue with the periosteum of bone. Remember that outer connective tissue layer of the bone, that dense bone tissue, that becomes continuous with this fibrous joint capsule that is going to surround that articular capsule. So besides the capsule itself, and that continuous connective tissue membrane structure that we were just looking at, we have a few different accessory structures that assist with these synovial joints. So first off, a meniscus is a pad that is either going to be composed of that dense fibrous fibrocartilage or sometimes adipose tissue that is located where the bones are going to potentially meet frequently. So we'll have articular cartilage lining that bone, and then you can have a meniscus, like you see here, that extends into those angles where the bones might meet as they flex, as that joint is moved. Very similarly, we have structures called fat pads that aren't necessarily already in position to protect against that movement, but rather act as like extra packaging material, like in a shipping container. So you add a bunch of those little soft peanut looking things or bubble wrap, and as the contents of that package move, those peanuts and bubble wrap are going to shift and help prevent extra damage, friction, contact between the components of that package. So fat pads are going to shift and change in shape as your joints move. Whereas a meniscus is already located in those areas where the friction is going to be common, the fat pad changes shape and shifts to fill in the spaces that are created as the joints move. We then have support, as I said earlier, from intracapsular and extracapsular ligaments. So ligaments within that joint capsule and ligaments outside of that joint capsule. So we can see the one here. This is an example of our knee joint. So we have extracapsular ligaments between the patella and the tibia. And then we have intracapsular ligaments such as the ACL and PCL, the cruciate ligaments within the joint capsule. Lastly, we have bursa or bursae for multiple. Like you can see here, all these little green things. And these are just small fluid-filled pouches or sacs of connective tissue, kind of similar to like the synovial fluid within that synovial capsule, within the joint capsule. They're just there for extra lubrication and extra support. Little fluid pads for protection. Okay. So that is a general structure, and we'll find all of these accessory structures in any of our synovial joints. And we're going to look at a lot of different specific synovial joints at the end of this chapter. But next, let's talk about movement. So obviously there's lots of different movements that our body is capable of, allowing us to interact with and explore our universe, our surroundings. And so we refer to or talk about a lot of these movements based on the plane and direction of that movement. So we can have gliding movements where the point of contact is essentially staying stable. The rest of the pencil here, the hand isn't moving, and those points of contact just glide across each other, right? Shift across each other. So they stay in contact, but are just shifting. That is gliding movement. An angular movement, the point of contact remains completely stable, stays in the same spot, but then one of those bones is moving around that point of contact relative to the other. And so if this is in a particular plane, so side to side or front to back, that is angular motion. The combination of those multiple angles around that axis would be circumduction. So the shoulder is a great example to use for circumduction, right? I am using both up and down and front to back angular movement, combining those things into this circular circumduction. And then last, probably the rarest of these types of movements is rotation. And so that is the bone itself rotating along that contact point. Okay, so as I rotate my glenohumeral, my shoulder joint here, right? The humerus and the rest of my forearm is staying on the same plane, but I can rotate the head of my humerus inside that glenohumeral capsule. Okay, rotation. So like I said, that's likely the rarest of these movements because there aren't a whole lot of joints in your body that are capable of that. Another would be the axis C1 on your C2 where they meet and rotate. Your hip joint can do a bit of rotation, right? But most are staying in their relative plane and doing these angular motion, circumduction, or gliding movements. Right. So the most common movement that we will be referring to is flexion and extension. And so if you think about anatomical position, I'm going to quickly stand up, right? Standing straight up, palms facing forward, anatomical position. In that position, all of the major joints of the body are at extension. The only exception is our ankle joint. Since our feet are semi-flexed, our ankle is partially flexed as it is in contact with the floor beneath us, but every other joint is at extension. So from that point, flexion is going to be any movement in the anterior posterior plane that decreases the angle between two bones. So as this person moves their forearm towards the front, right, in an anterior motion, that would be flexion of the elbow joint. So I'm flexing the elbow joint, extending the elbow joint, flexing the elbow joint, extending the elbow joint. Right? my neck is still in an anatomical position. So I can flex my neck, decreasing the angle in this anterior plane between my skull and my chest, flexing, extending. So any extension posteriorly, or not, it's not always going to be posterior. Most extension is posterior, but any extension beyond where that joint is in anatomical position, that is hyperextension. So we can see hyperextension of the neck here as we tilt our head backwards, hyperextension of the hip as the leg is being rotated backwards posteriorly. So any extension beyond anatomical position is hyperextension. See that with our wrist here as well. So again, at anatomical position, all joints are at extension. If you decrease the angle of that joint anteriorly, or gosh, I keep saying that. It's not always going to be anteriorly. There are going to be some exceptions. Or is that even true? Let me think about that further for a second. So I don't know if I can say that with 100% certainty, but as I'm thinking about it, all the examples I can think of are anteriorly. So almost all, if not all, flexion, decreasing the angle is going to be anterior movement from that anatomical position. And if you go further posteriorly, that will be hyperextension. So that's only on an anterior posterior plane. If we're going longitudinally away from the midline, that's where we get into abduction and adduction. This is movement away from the longitudinal axis. And so not anterior or posterior, but away longitudinally in the midline. So abduction, to abduct something is to take it away. So abduction is going to be longitudinal movement away from the midline. Adduction, when you add things, you put them together. So adduction is going to be towards that midline or middle digit, right? When considering our fingers and toes, you can abduct the fingers and adduct them no matter where they are relative to the midline of your body. So that is abduction of the fingers and adduction. Circumduction is just any kind of circular movement like that, as you see with the shoulder joint here, circumduction. Okay. And then we have rotation and supination and pronation. So rotation, as I said, is on that, like the point of contact remains stable. And then one head essentially is rotating around the other, spinning, right? Whereas in the case of circumduction, like the head, where all the places that it's contacting the glenoid cavity of my shoulder is relatively the same. It's just kind of moving around that space. But now if I rotate that, right, the head is actually shifting in that cavity. I don't know if that's a great explanation, but we can see rotation of the shoulder here, rotation of the skull, the neck joint, right, rotating around that axis. Supination and pronation allows for a more distinct description of rotation relative to things like the thumb or palm. So we can supinate our thumbs outwards or our palms upwards, and we can pronate our thumbs inwards, medially, or your palms posteriorly or towards the ground, depending on how you're holding your arm. But this mainly is just referring to or used when referring to the movements of your forearm. So supination to bring your hands into anatomical position, pronation to bring your thumbs facing towards your midline medially. For our feet or our movement of the ankle joint, we can refer to movement towards the midline. So medial movement here as inversion, and then lateral movement here is eversion. So pointing the bottom of the foot towards the midline is inversion, pointing the bottom of the foot away from the midline is eversion. And then we have specific movement for the ankle joints, dorsiflexion and plantar flexion. Because it isn't at extension when we are in anatomical position, movement from anatomical position in both directions is given its own name, which I find unnecessary because we could just call this ankle flexion and this ankle extension. But we do have these two different names. So dorsiflexion, dorsally, superiorly, is flexing the feet up, flexing the ankle up pointing your toes towards the sky. Plantar flexion, think about plants on the ground. That is actually ankle extension. It's pointing your toes towards the ground, towards the plants of the earth. And then we have opposition, which is only used to describe the movement of the thumb. And it's pretty unique saddle joint opposition towards the opposite side of the hand, or towards the palm. And then we have retraction and protraction. I actually had someone in lab yesterday ask what's the difference between protraction and retraction versus abduction and adduction, which I think was a great question. And I now have a better answer, which is based on the plane of movement that it's in, because this is anterior posterior movement, but we don't have flexion and extension like we do with our other joints. So this protraction and retraction of the jaw is very similar to abduction. Right? So moving away from the midline, protracting forward, and then retraction back towards the midline, very similar to adduction. But we really just use this terminology for the movement of the jaw. You may also see it used for the movement of the shoulder, so of the scapula, but that's better described as abduction and adduction. So you can protract the scapula by abducting it, and you can retract the scapula by adducting it. But the abduction and adduction are more accurate. So this terminology is just because it doesn't follow that longitudinal plane idea or rule. Another set of movements that is basically just reserved for movement of the jaw, but I suppose you could use it for things like the shoulder joint, would be elevation and depression. Right? Elevating superiorly, depressing inferiorly. Right? Really just used for the jaw joint. But I could see it as simplifying the flexion and extension of the shoulder, which gets a little strange to try to describe because of the wide range of ability that the shoulder joint has. But elevating is up, depressing is down. And then we have lateral flexion. So we had just straight up flexion, which is on the anterior posterior plane. Now we have lateral flexion for joints that can move in a strict plane, but in that lateral direction, right? So lateral flexion of the neck here. Like, what did I skip here? Oh, I just didn't talk specifically about the rotations. I was waiting for this to come up, so I apologize for that. So when rotating a joint, so keeping that contact point stable, are generally the same, but just rotating within that joint, you can have lateral rotation away from the midline and medial rotation towards the midline. So keep that in mind as well. Lateral rotation is away, medial rotation is towards the midline. Okay. And I think that's where I'm going to stop this video for now. In the next one, I'll talk about our 6 different types of synovial joints, and then look at the specifics of the structure of our elbow, knee, shoulder, and hip. I will see you in the next one.